welcome, guys. Thanks for coming back a year later. We all don't look any worse for wear. Well, most of you guys don't look worse for wear.
Some of us.
So thanks for coming to the Fireside Chat. This is part 2. I think last year we called it 12 Days of Carotid Stenting, but that only goes once. So this is our Fireside Chat part 2. And I thank you guys for coming back together. I think it's been a monumental year for carotid stenting, and it's always fun to look back and see what we said a year ago and how things have come together. I don't think any of us would have imagined that everything would fit together so nicely. A new face in the crowd, Pat Muck's with us today from Good Samaritan Cincinnati.
Thanks for having me.
Pat is going to lead as one of our PIs for our C-Guardians 2 trial, which is our TCAR trial. So thank you for joining us.
Thanks for having me.
Sean Lydon from the Cleveland Clinic back for round 2.
It's good to be back.
It's good to have you back. Chris Metzger, the man with the plan, our carotid guru here who led our C-Guardians trial, and maybe we can talk to a few of those results that we just talked about. Aviva and Kenny Rosenfield from Mass General, back with us again for the second year. And Shane Gleason. I don't know what he's called. Shane Gleason.
Wants to be Sean.
Yeah, everybody wants to be Sean. Our Chief Commercial Officer with the company. So guys, let's jump right into it. A year ago, on this eve at VEITH, we sat down together and we started the discussion on how do carotids feel in the current space. And all the buzz was this move toward the NCD with getting standard risk reimbursement. And I think everyone was optimistic, but cautiously optimistic for a variety of reasons. Many years since this had been reconsidered, lots of changes. I'd like to just go around the room and get your perspectives of what that change has done in your mind and how that changes the field of carotid stenting and how you anticipate those changes both for the patient and your practice. So maybe we can go around and just do some feedback. You want to start, Chris?
Sure. So I think the national coverage decision, first of all, it was a yeoman's effort on CMS. As everybody knows, they really looked through the data, and rather than opinions and territories or anything else or finances, they looked at data. And I think it was pretty compelling, and everybody would agree that it deserved the more broadened coverage that we see now. And so now what that does, I think, is it lets the playing field be leveled. Now we can consider carotid stenting along with the other technologies, and instead of looking at who's covered for what, we can look at what's the best therapy for the patient. And I think that's what we've all wanted for a long time. It does a lot of other things for the field as well. It lets technology move forward because industry now, who has been on hold almost for 20 years, is now going to pump more into the space to advance the field even further. And as we've all seen, not only from lessons learned, but from newer technology that we have had, some of which we're going to talk about, the results keep getting better. And that's what we want to keep going to. So now it brings us into a spot where it's in our armamentarium to consider as one of the viable options for treating folks with carotid artery disease.
Kenny, what are your thoughts? You were a big part of the MSCA, and this was somewhat of a life's journey.
Yeah, it's been a heavy lift, but I just want to echo what you said, Chris. It's kudos to CMS for doing the right thing on behalf of the Medicare recipients who are now going to have access to this. This is all about patient access in one sense. It's also about, as you said, normalizing the carotid stenting and making it similar to, I like the analogy of I'm a cardiologist and I do a lot of coronary stenting, and my patients come in and I can either choose with them and the surgeon, make a shared decision between whether the patient's appropriate for a coronary stent or a bypass surgery or medical therapy. And this makes carotid stenting basically puts it in the same realm, which is a really healthy thing. I think that it has been a long journey. The organization that actually requested the decision was made up of some of the people in this crew here. Certainly Sean and Chris were part of that. It's called the Multi-Specialty Carotid Alliance, or MSCA. And that really is about, the name says it all. It's a multi-specialty group that came together and said, we really need to do this on behalf of our patients. And I think right now, what I feel in the past month is more a sense of relief than anything else that it actually, the right thing actually happened. And again, kudos to CMS. We could talk a lot more about the technology and what it means for patients, but that's my first go around.
Great. Well, yeah, I think we should get into the topic, but high level, that's a good place to stop. So guys, I didn't mean to separate vascular surgeons from
And we're all, we get to look at each other right across the table. It's all good.
We're in alliance.
That's right. There's no fighting here. So from a vascular surgery perspective, thoughts, guys?
Yeah, so carotid disease and carotid care was the only place where I could do carotid endarterectomy. I could do medical management, I could do TCAR, and I could do carotid stenting. But after I decided what are the options for my patient, I'd have to look to see who their payer was before I'd have that discussion. It was always completely awkward. I think the nice thing is that, the MSCA came together to say, there's data to support this. I applaud CMS for evaluating the data. But to me, it's going to be a win for patients because it has created a huge buzz in the medical community about carotid disease. And so there are plenty of patients who meet criteria for screening who have carotid bruits or have multiple other beds of vascular disease, where now you might have screening and have more patients be recognized. We know that patients with asymptomatic disease that have greater than 70% stenosis benefit from carotid revascularization. Now we can have discussions with our patients of who's appropriate. And so to me, it's a big win. I think the people who are going to be good at what they do may be able to offer one therapy, two therapies, or all three therapies. But I think that's where you can have shared decision-making with your patients to make sure they have good outcomes. And to me, really where the win is that it now puts it in the hand of the House of Medicine to make sure as a hospital and a health system. I work at the Cleveland Clinic. Right now, our neuroradiologists, our interventional neurologists, our neurosurgeons, our cardiologists, and the vascular surgery team is coming together to make sure our credentialing all ask for the same credentials to do carotid stenting. And it was approved for carotid stenting, TCAR, or transfemoral. So it's showing that stenting works. It works equivalent to surgery. And so I think it's a huge win for patients when they can have all three options. There's going to be patients best treated by one, best treated by one, best treated by one, or can have any of the three. And so I think that's what really, there'll be patients who want each of the three therapies.
Yeah, I think from my perspective is not being a part of the MSCA and really wasn't certain if the decision was going to come down. And obviously I wasn't here last year, kind of the junior member, but I think what, I would think represent more likely the 2/3 of the Society of Vascular Surgery field out there, where I'm private practice, I'm academic, I'm a program director, but I think that's more in line than non-university, and I think that it is exciting to see now that we have all three options: CEA, TCAR, and transfemoral, where we didn't have that for so long. And the reality is that if you do CEA long enough, or there's going to be complications, the high lesions. Those folks, without a doubt, have cranial nerve issues, and so to be able to spare that for folks who aren't TCAR candidates and aren't CEA candidates now offer this, I think is exciting, and the future is pretty bright with this technology.
Great. So let's stay on that topic for a second. We're often asked from industry's perspective, what's the total available market? We always talk about 155,000 or so carotid interventions a year. Does this drive greater patient awareness, easier decisions, and more opportunities to have those discussions with patients earlier in the disease process? Does it stay the same? How do you feel this is going to impact sort of this overall intervention versus staying the same? Does it build that opportunity for patients to get, as I've heard you say before, Dr. Metzger, sort of one and done?
Yeah.
How does that feel to you?
I think it feels great. And the hope is it's not going to change it a whole lot. Because what we really don't want is for people to go out and do a whole lot of stenting that may or may not need to be done. So it's still, but it just now, again, gives us the option. Where I was previously in Kingsport, we had a pretty good relationship with our payer. So it didn't affect me as much as maybe some of the other people here. But it just allows us to, instead of looking at we had to look at the carotid endarterectomy risk. Okay. Now we can look at the carotid stent risk, and the whole totality of their clinical picture and then make an informed, good decision where, as you said, Sean, we don't have to look at the payer mix to see how the discussion is going to go with the patient. The number of people that said before, I want to stand, but I can't have it because of my insurance was frustrating for everybody. Now, there's going to be more availability and it'll be up to us to then be responsible with that availability and to still look at the entire picture and say, what's the best therapy for the patient that's in front of you? And sometimes it's going to be medical therapy. A lot of times it's going to be medical therapy, but at least now we have the option to really go independent of whether they are high risk for endarterectomy, whether they were symptomatic or asymptomatic, and what their insurance was. Just make a good decision for that particular patient in front of you.
Any other thoughts on?
I do think there will be more public awareness. I think people hopefully will go to their doctors. And a lot of it is risk factor management, getting them to stop smoking, getting them to get their cholesterol managed, get their blood pressure managed. But I do think because of the buzz around it, it'll create some more of the internists looking at the guidelines of who needs screened, how to screen people. And we do know that the asymptomatic population has a higher stroke and death rate. And so getting those people in, getting their risk factor managed, if it's appropriate to have more procedures, I think that's actually fine. I don't think we should be doing more procedures, but I do think when you create awareness about stroke prevention, which is horrible. I mean, people fear stroke more than just about anything. To be disabled and to be maimed is a very life-altering thing. It's very costly to the United States and to the world. And so, with awareness, I know with TCAR coming on, we get calls all the time. Do you do TCAR at the Cleveland Clinic? And people seeking out TCAR. When transfemoral now is in the field, you will get those same calls. Do I have all my options if I come see you? And now that we can say yes, that will clearly drive patients where they go seek care.
Yeah, I agree. I totally agree, Sean. I think the key is not to, as you said, Chris, we don't. This is not a sign like we're not at the horse races and suddenly the gate opens and the horses run. We don't want that. We want a controlled situation where it shouldn't change things that much, but I think there will be a swing towards less invasive procedures. Patients want less invasive procedures. So I think there will be probably less endarterectomy and more carotid stenting. I think there'll still be TCAR. I think it'll balance out. And I think the overall demand will increase. What really excites me is as you mentioned earlier, the technological advances that are going to happen as a result of investment in this now, knowing that there is going to be at least reimbursement. Coverage, the absence of coverage before really held things at bay in the investment community, and without the possibility of investment, nothing's going to happen. But now, I think there'll be investment. I actually believe that we will get the stroke and death rate down to stroke MI death rate down to less than a 0.5 percentage point, which will be a real target. That changes the equation. I mean, if you can get a stroke and death rate that's less than 1% and even less than 0.5%, then suddenly the calculus between staying on just plain medical therapy versus the one and done becomes clearly in favor of the one and done. So that I think will actually push the field forward.
Especially when it's a durable therapy. In other words, once it's done, the restenosis rate is extremely low. The patency, long-term patency we know from 10-year published data is very, very good. Yeah. So you can do it safely, and once you do it safely, it's durable.
It's durable, and the stroke rate is also very, very low.
I think if you look at the last 15 years, stroke rates have come down. That's really been about us understanding what anatomies are best treated or not treated with stenting. And so now I hope, now that you can level the playing field, we can start working with industry to start defining new therapies to treat those patients that maybe don't do as well that we've identified, whether it's arch disease, long lesions, thrombus-filled lesions, calcium. And so I think that's the nice part is, there's really been very little investment in the space. We've gotten better and better at what we do because we've identified who don't do well. But now, I look at the same thing for the aortic space. 85% of patients get a minimally invasive repair. Why? Because there's less pain and suffering. When the outcomes are equivalent, what do people choose? And so carotid surgery is still carotid surgery. They're all one-day stay, but one has an incision with nerve issues and one does not. So, as technology improves, we've not improved on, carotid surgery's had about a 1% risk of stroke or less, but it still has, a 4 or 5% cranial nerve injury rate. And that's not gone down over the last 20 years.
Well, TCAR has been the one technological advance that's happened over the past 10 years, and that's actually a good thing. I mean, it's been a very positive advancement, I think, in that we can do better TCAR as well. I think we can improve on that too.
So let's talk about that a second, because we as a company, InspireMD, made a strategic decision to invest in both, right? It was all built around our fundamental strategy that the implant ultimately determines clinical outcomes. And so we focused our attention on a mesh-covered stent and decided that we weren't going to pick either side of the aisle. We were going to create an environment where whatever the choice was, the procedural requirement, whether by TCAR or CAS, that was secondary to making sure that you chose the best implant. So we made a big investment in that space. And it seems that from the feedback, you feel that TCAR will remain a viable option for neuroprotection, and CAS obviously will grow because it's been the area that's been somewhat reduced by way of payment.
Patrick?
Yeah, no, I agree. Building upon what Sean said before, I kind of fought TCAR years ago because, let's be honest, perhaps the technology wasn't the best with the implant that you were leaving. And with that, still had very good results, but there's room for improvement. And this new technology is incredible. I think TCAR is going to go away. No, you're still going to have complicated arches with high lesions that make more sense to do a TCAR, as long as it's not, thick circumferential calcium. So I think there's still going to be a role for it. But I think the fact of the matter is that the majority of the folks are going to end up with likely a transfemoral approach as we move forward, because the technology with, if I remember correctly, 45,000 plus implants so far and incredible results with this mesh technology, I don't think there's any doubt that that's the future. TCAR is not going away, CEA is not going to go away, but they're definitely going to be a shift towards a transfemoral approach.
And these are really complementary. So in the trial, Pat, that you'll lead, the SwitchGuard trial, if you think of TCAR with great embolic protection, flow reversal during the procedure, okay, and before you even touch the lesion, even with a guide wire, if you take that degree of protection with the degree of neuroprotection the stent offers, at the critical times of the procedure, the stent and the post-dilatation, that's when there's a plaque protrusion. This obviates that or minimizes it. And post-procedure, whether you have TCAR, whether you have proximal protection, once the protection is done, the plaque protrusion issue still persists afterwards. Now, this stent will take away that part, so you've got protection during and after. And if you come up with 75 or 80, I think is what your shaft length is, now you've got a better stent. If you're a TCAR person, you like that, or if it's the best for TCAR, now you put the best stent with the best embolic protection or access route for that patient. It's complementary.
Got it.
Well, I think there'll be innovation. I think at some point we'll be able to develop a way to do TCAR percutaneously. So we won't have to necessarily do a neck cut down to do to flow stoppage, where it'll continue to innovate. And so if we could do that, I would completely stop doing the cut down. I think TCAR gets rid of all the art stuff. And so I think that we will see, 5 years from now, we will probably, if we ever sit in this room, we'll be smiling at how infantile we were in our TCAR approach, because there's only been one player in the space and they haven't innovated their stent, and they've not innovated a ton their protection. And so I do think now there will be a lot more innovation in this space that will actually, be worthwhile, because there is potential ability to do it. You don't have to worry about how do I get it through, how do I get it paid. Now it's stenting works, whether it's transfemoral or transcarotid.
Yeah, I think that TCAR is going to stay. It's a good technique, and I think that needs to be improved upon as well. And I think there's a group of surgeons, maybe the vast majority, who've trained very well in TCAR and do it very well, and they're going to not want. They like that technique. They cannot not want to abandon it. I do think there are differences that we haven't talked a lot about, but one is the cost. And if we can do TCAR percutaneously, then we eliminate the need for an anesthesiologist, OR time, cut down, and so on. And that isn't talked about very much, but I do think transfemoral may be able to be done at a lower cost and pure transcutaneous TCAR also might be done at a lower cost. So we'll see how that unfolds.
So I'm not going to put you guys on the spot to fast forward 2 to 3, 4 years down the road and ask you for percentages of, what percent of the stenting market is CAS versus TCAR otherwise. But do you envision a move where, let's call it a 30-70 in today's world, surgery to intervention becomes 70-30? How do you see this switch from standard of care being endarterectomy to stenting becoming standard of care, or is that the way it?
I mean, I would say from the surgical standpoint, aortic work, 85% endovascular. Lower extremity work is now 85% endovascular. With therapies with equivalent outcomes, the carotid will become no different. If a patient has a choice of a surgical incision versus a puncture with equivalent outcomes, that's what patients choose. That's what my family chooses. That's what most families choose. And so I easily see 3 years from now it being 30% of the market surgical and the other 7% stenting. And depending on how technological advances come along, this percentage will be transfemoral or brachial or radial, and the percentage will be transcarotid. And so I think, 3 years from now, it isn't 70% of the market share. I would be shocked.
Do you think, so Pat and Sean, question for both of you, a lot of the access for patients who they see with the carotid disease is the vascular surgeons right now. And there's been an era where they haven't done transfemoral stenting. There is a learning curve for that. Do you think folks are going to look towards that learning curve to learn transfemoral or transbrachial? Or if you're very comfortable already with TCAR in your percentages there, Sean, I just wonder if folks see a vascular surgeon rather than a non-vascular surgeon, are they going to get transfemoral, do you think?
My opinion would be that people 15 years out and less will want to adopt transfemoral. Maybe the people that are a wee bit older, because the learning curve is less steep with transcarotid, probably won't want to adopt something new, saying, I already got 5, 10 more years of my career. It's not worth it. I can do enough that it doesn't matter. But I think the younger population that is doing everything else percutaneous will want to make that part of their armamentarium.
What do you think, Patrick?
I can't agree enough. We're in the middle of interview season right now for our residency and fellowship, and I tell the applicants, I'm like, you need to learn transfemoral carotid stenting. Patients are going to ask for it. It's a Band-Aid. It's got great results now. It's got incredible new technology, and so I think that I think there's going to need to be some courses, you three, and hopefully I can tag along with you. You're going to have run some training courses to teach.
You'd be welcome.
You can't escape.
But I think that, as Sean alluded to, folks, early out up to 15 years, they're going to need to undergo transfemoral carotid stenting courses on, cadavers, or, at our hospital, we have a swine lab. However we're going to do it, I think folks are going to need to learn it. And then fast forward in 3 to 5 years, I think it's going to be probably 10-10-80 would be my call. 10% CEA, 10% TCAR, and the rest transfemoral.
Well, I'm not so, I agree that there's going to be a trend. I'm not so convinced it's going to be that rapid, because I think there's a lot of ensconcement in the surgical community and in TCAR, which is fine. I actually think, for patients that are equal candidates for transfemoral or TCAR, then TCAR is fine. It's a good option.
This is a first, right?
For me to say this?
The interventionalists arguing for TCAR and the surgeon arguing for CAS.
I think it's a good, they're both good techniques, but just to, I think the real important points here are what everybody's saying, is that training, education, awareness, being open-minded to transfemoral is also important. I had a discussion with a less than 15-year, a 5-year out person this morning who said, well, I really prefer endarterectomy. And I just think that person has grown up in the era of endarterectomy being first. He's in New York, it's a conservative place. So we have some education to do and some awareness. Let me just, can I comment on that? Because I think the MSCA, we're not done with our work. In fact, our work has just begun. We as a group intend to really focus our energy on making sure that what happens next is the right thing, right patient, right quality, right doctor, right awareness, right data being collected, all of that needs to be strategized up front, hopefully with the help of industry. Develop a curriculum, standardized curriculum for all specialties, get all the specialties to work together, which is what we've done pretty well, and to, yes, have training courses, practicums at all, like at the VAM, for example, at VEITH, to have hands-on courses where people like who are the best guys in the world, like Chris Metzger, can actually teach us how to do them, teach everybody how to do this the very best way.
Yeah, I think that's right. From industry's perspective also, this is a new frontier as well. So we've got to double down on our ability to be responsible in this and make sure that the operators aren't a small number of people that are highly proficient. We've got to open that up to safe stenting, whether it's by way of TCAR or CAS. So it's a.
I love that, safe stenting. That's a great.
And all the big strategics are being hounded by physicians now. How do I get trained? How do I get trained? And societies do a good job of running courses, but they're slow to adapt and slow to respond. And so I think that's the reason why the MSCA wants to sit there and say, okay, here would be a multi-societal understanding of what patients should ask, what doctors should have for training, and a way to train people. Because I think, instead of everybody doing something different, the more you have it so that these are the patients that are going to be best with the surgical therapy. These are the patients who might be best for TCAR therapy. These are the best that may be for transfemoral, and understanding the anatomies. Because I had to do 100 transfemorals with Jay Yodoff, Dan Clare, Chris Bajer before I was allowed to do an independently. And when I first started doing it, I was terribly intimidated, but afterwards I realized I got to not have a learning curve in terms of outcomes. And, you can't sit there and say, it takes 100 to do this, you have to accelerate. I think that's why TCAR will continue to exist, because we know the learning curve may be only 15. But the more we can put out there, here's how to learn, here's how to do it, but here's also the outcomes that people should be held to, because it's not just learning, it's making sure that institutions and the medical executive committees can hold all of us, every specialty, to appropriate outcomes so that patients continue to get good, safe care, including medical management.
I think it's critical. And I was going to ask you a question. It's kind of along the same lines. What is going to happen is exactly what you said. The youngest folks out there are going to come to you and every other industry say, I am a great operator and I want to learn carotid stenting. Now, we have to be able to put the appropriate brakes on that. Just because you want to do it or think you can do it should not be it. And I think that's how we'll kind of coach folks, but even be a support arm for industry. Say, sorry, Junior, you want to do these, but you're not quite there yet. You haven't done any other vascular cases. You're still in fellowship. This is not the procedure that you're going to come right out of fellowship and learn because you went to my course or one of our courses. And so it is one of those that we really will have to help at least come up with guidelines between societies, the MSCA, and the hospital level so that the right people are doing it. And after they've got the appropriate amount of training that you just talked about. Because your first 5 is not going to be the way to learn.
Yeah, that's right. I mean, I think as much as we want to focus on the best implant, proficiency also determines clinical outcomes as much as anything, which we've experienced 45,000 stents later and other things. And ultimately, this is our business. Unlike a lot of the big strategics, this is what we have.
It's proficiency and judgment and case selection.
Even for the big strategics, I mean, frankly, good outcomes. I actually firmly believe that our industry partners want the very best outcomes for their patients. It's not all about just the money and just selling their products. It's about getting better outcomes.
Well, it also seemed, Kenny, that that's part of what CMS said as well. I think they were very neutral on the topic of oversight, basically pushing it back to the hospitals and societies to oversee the relevance of this and the safety and the importance without mandating things, but saying very clearly, it's yours to make sure this.
This doesn't mean that outcomes don't matter anymore. It's just pushing the.
For every other part of medicine, that is the job of the hospital and the hospital credentialing committee to monitor to make sure physicians are safe and appropriate. So it's put it back where it always should have been. but it's upon us to make sure we're responsible with it and that we work collaboratively amongst all the disciplines who can do this.
But it's a movie that you've seen before, as you said, Sean. I mean, this is the last vascular bed to really shift over to endovascular standard of care. So it's not like coronary and aorta and other areas haven't gone through this transition. But, it's a big step, for carotids, right?
But I think it's also our responsibility as physician leaders to, and leaders of societies, leaders of the MSCA and so on, to actually ensure that we give the tools for local hospitals to be able to evaluate and ensure that the highest quality care is being delivered and that the right patients are being selected.
And we all want this, and, I don't know if we're going to get to the results or the two late breakers that were presented at Viva, but, the astounding results that are better than the TCAR results even, quite honestly, they are. I mean, the numbers are better. Stroke, death, and MI at 30 days are better than Roadster 1 and Roadster 2. And in part, that is because not only the experienced operators, but the screening committee that goes along with that. Just like CMS very appropriately said, you must evaluate the arch pre-procedure, whether it's CT angiogram, an arch angiogram, a few instances, MRA or whatever, and then select out those who are good for the procedure by operators who know what they're doing. That is a key to everything, and that's why we were able to get the incredible results of 0.95% stroke, death, and MI at 30 days. That's unheard of, in people who are at high risk for carotid endarterectomy by definition to get in the trial, 25% of whom were symptomatic.
It's funny because you just reminded me, these trials have all been done with high-risk patients for endarterectomy, which means that they're usually sicker and older and more challenging. And, we really have not had the opportunity to use carotid stents very much in the younger, healthier population. And that actually, again, provides me more encouragement that we can actually get to stroke rates and death rates that are less than 0.5%. I think if the totality of patients might actually even be better.
I think if Gary Rubin had his way, he'd want to train everyone by himself, right? Personally.
I was blessed to have been trained with him.
Right.
And so a lot of that has stuck with me. And I will tell you, folks, that's a man who walks the walk, that doesn't just talk the talk. He would walk away from a case, and as a young and eager guy, he would say, Junior, learn, just do not do that case. And he would do it every time. And that's what we should all aspire to.
That's an important point. Is if you start with the question of, is this a stentable lesion? And if the answer is no, walk away. And if it is, then you can get into the questions of how to best approach it. And if there's anatomy that steers you away from doing transfemoral carotid stenting, that patient may be great for TCAR and vice versa. But starting first off, if it's a stentable lesion, and if not, endarterectomy.
Shane is one of the highest volume carotid stenters. I'm the first guy to call, or first to tell the patient this isn't the procedure for you, and secondly to call a surgeon and say your procedure is better than mine. Sometimes TCAR will do together. Sometimes endarterectomy is heavy calcium. It is not. You never force a carotid stent ever. There's no reason to do it.
So let's change gears a second and let's talk about the background on one of the key bellwethers of the carotid intervention space, which has been CREST-2. Everybody has hung a lot of anticipation on CREST-2, not anticipating that this NCD was going to occur in this window of time. I guess my question for the group here is, how does that feel relative to the value and importance of CREST-2? Does it feel the same? Does it minimize it? Will the horse be out of the barn, so to speak, by the time CREST-2 is read? Because there'll be so much other data for the next 2 years. How does this fit?
So I'll always take a first step because I'm a member of the Society for Vascular Surgery, and they came out pretty strongly negative against CMS changing the NCD and said we should wait for CREST-2. And I was blessed to have Tom Brott as part of the MSCA, who's one of the national PIs for CREST-2. And CREST-2, people have to realize, is best medical therapy versus best medical therapy with stenting, one arm. Best medical therapy versus best medical therapy with surgery. So it's not going to answer anything about surgery versus stenting. It's going to say with what we have today for cholesterol control and blood pressure control, if we drive to goal. So this is the first trial that really the committee gives you feedback. Is your patient at appropriate blood pressure goals and cholesterol goals? how does that affect the need for the procedure? We might find it, less people need stenting, or less people need surgery, or both, or that best medical management enhances the outcomes together. So it'll add to our carotid knowledge, but it's not going to sit there and say, do we need surgery? Do we need stenting? Because it's not looking at that question. And many people confuse the fact that that trial is comparing those two. They're separate arms that have different data points.
And there's we have to put CREST 2 in the totality of all the evidence we just talked about. First of all, it's 9 years and counting. It's not enrolled yet in the carotid stent arm, despite 100+ centers. Okay, let's start there. Number two, it's very similar to coral in some ways. I mean, that we're taking low-risk folks, a 70% that it's not a big deal and you put them in, but a lot of people are not putting the 90% lesions who benefit most from revascularization. So even if it's a tie, and by the way, we're in CREST 2, and the real world amount of diligence with getting their blood pressure systolic less than 130 with a blood pressure cuff and so on, adjusting medicines constantly, that's not real world. Okay, it's not what folks are going to do. We want medical therapy. But even if it's a tie, you still have the option to discuss with your patient. You have two options. 70% lesion, it's reasonable based on this to continue medical therapy and call for their symptoms, realizing there's a little bit of risk of an unexpected stroke that we can't predict. Or we could do a carotid stent and at low risk, and then you're done. So it can be one and done, as we talked about earlier, or you can go medical therapy and we can still involve the patient in an informed decision. But it has to be put in context of everything else. It's not the end-all, be-all answer for sure, especially enrolling a lot of 70% patients.
Patrick, what's your perspective on CREST 2?
We were in it as well. We found it very difficult to enroll folks for reasons Chris said. You're looking across somebody who's 71 years old, maybe high risk or whatnot, but they got a 90% carotid lesion, and you tell them, hey, listen, I want to enroll you in this. You may not get surgery. Well, then they go back to the medical doctor, and the medical doctor never sends you another patient again because they're like, well, how's he doing this? Letting somebody walk around with a 90% lesion. So we found it very hard to enroll in it. I think it's a very important trial, of course. It's very important to the SVS. But I think at the end of the day, it's not judgment day. It just adds to the body of literature, and it's not taking into account technology. Technology changes and devices get better, and the results that Chris is alluding to are phenomenal.
Patient selection has gotten better over the course of that 9 years. Operators, in some instances, have gotten better. And I agree. I mean, we're part of it as well, and I found it extremely difficult. Actually, the patients, when I try to do a shared decision-making process with them, which is something else we can discuss about the NCD, but when I explain to them, you have this 90% lesion that's pretty tight, but, I think that we don't know if you might do just as well, just not treating it all. I have patients either respond one way or the other. They either say, I want this fixed, period, and they don't want to enroll in the trial. Or they say, I don't want to be touched at all, just leave me alone. I'm, 80 years old and I'm fine. It's one way or the other. I have very, very challenged to, doc, you don't know the answer to that? How could you not know whether a 90% needs to be open or not? And it's very challenging. And I'm committed to the trial. It's a really important trial, but I share your concern. A lot of selection bias is happening in the trial.
We were a site in Cleveland, and the exact same experience we had, that patients say, no, please fix it, or no, please just let me medical manage. And it was really hard to get anybody to randomize. And if you don't get a randomization in your first year, we were let out of the trial. And so I had to approach, tons of patients, and they were like, no, I want just medical management, or I just want, a stent or surgery. But to get people randomized was very, very difficult, because patients just don't understand how you can say, well, we need one or the other. And then they come with a bias of one of the two, and then
or their referring doctor comes with the bias.
Right.
But to be sure, just to get back to what you said earlier, Sean, this is a trial that is looking at medical therapy versus revascularization. And once a patient is, the decision, the NCD really doesn't have anything to do with that. The NCD says once you are a candidate for revascularization, you now have the ability to have the equal consideration of these different options. And the trial really is, it was the protests against the NCD on that basis were really not on target, because they really don't have to do with whether to get revascularization or not. They have to do with which.
And as the
which
trial
things
is
are
not even
available.
done and it has 4-year follow-up, we could not kick that can down for 5 more years.
Right.
It just would not be fair.
I could be wrong, Kenny, but, and I love Suresh Vandantham. He's an incredible human and a great researcher, but I sometimes wonder if CREST 2 will be analogous to the ATTRACT trial. That was a great trial, but now there's new technology out.
Right.
And so it's super important, the largest randomized controlled trial ever in DVT, of course, but things change.
Yeah, so moving target, that's a problem in all research, frankly. As the moving target, as technology gets better and better, your results get better and better, and how do you then integrate the trial results that were done, 10 years ago or 5 years ago? Very hard, but.
Good. So as we sort of roll up to the top of the hour, thank you guys for your time, and this is remarkable to be able to pull this together. I guess my final question, and unless there's other topics, is fast forward a year. We were sitting in this very room at the same time last year. Could you have imagined the magnitude of change, right? Kenny lost a little bit of hair, maybe.
I lost a lot of hair, and it got gray.
I lost a lot of hair.
I lost the hair, but it was
Okay.
But yeah. Chris did
okay.
All I got.
He had a lot of radiation. But I guess my question for you guys is fast forward a year and think about, because we want to revisit this at least on an annual basis. I like the format. What sorts of things do you anticipate we'll be talking about a year from now, on this topic or others? And are there other topics in this space that you feel like will become more or less relevant?
Well, I really hope we're talking about what a great job that the medical community did in onboarding and releasing this therapy and being appropriate with it. I hope that we hear great results of the 1-year data from the C-Guard device. I also hope we hear we've completed 2 new direct carotid access trials. Contigo Medical's doing one, InspireMD's doing one. And I hope that we hear that there's other investments in the space so that the technology continues to improve. I mean, we've seen the best results for carotid stenting 2 weeks ago at VIEW ever. Beat any device, any trial ever out there, less than a 1% risk of stroke death and MI at 30 days. And so if we can do that when there wasn't ability to get many patients treated, what's going to happen when we can?
Great answer. Okay.
And I think I built upon what Chris said earlier, is having, good training and teaching folks that it's okay to bail, and that it's okay to look at a CTA and say, this one might be CEA, this one might be TKR, or this one's transfemoral. I think that teaching courses and training is huge. And I think that if it's done properly, I still predict that transfemoral is going to kind of go like that hospital administrator graph where you see they go through the roof. I think if we train them the right way and teach people when it's good to do and when it's not so good to do, I think that graph's it's going to go up pretty quick. But I think that teaching courses and are very important the next year or two.
I hope a year from now what we'll see is a beautiful blend of multidisciplinary collaboration on this subject. So that instead of silos, I've got this therapy, it's better than your therapy, they're all good therapies. And if we do the training together, as you mentioned, Patrick, if we learn from each other, that's how the field of vascular medicine, the vascular field has gotten much better. When we all collaborate, it's in the Viva model, for example. That's when the best outcomes are. So if that happens, if we do this responsibly, if we train people not only how to do it, but when to do it and when not to do it, and if everybody takes ownership of this together, then we're going to be in a really, really good spot with the technology and the procedure that we have. That's what I really hope we're going to smile about next year.
Well, I guess I'll just echo what you said. I hope there's some kumbaya we can all sit around the table and have kumbaya with all the different specialties being involved. And I really do hope we work together. I hope that we can look back and say this was the right decision. It was good for patients. Patients are benefiting. There's more access for patients. Patients are more informed. We haven't talked a lot about that, but patients need to be more informed about what their options are. I'll be interested to see how the surgical world, for example, I mean, one of the parts of this NCD was that you are sort of bound to tell the patient all of the different options available, which is natural part of informed consent and shared decision-making. And I hope that that's now achieved a new level to benefit patients, frankly. So, yeah, I think it's pretty exciting. And then lastly, I agree with Sean. I really hope we see some spark in the investments in making this better so that we can have a moving target, then it can move to the right space even better and better.
Great. Any other topics we missed, guys, while we're finishing up? Anything off the table we didn't talk about? Other therapies, other investments, other interesting topics?
I mean, the only thing I would say is the MSCA, efforts will be now directed towards the training, education, and awareness, and also giving tools to docs so they can actually carry out the shared decision-making model that was mandated really by CMS. So that's going to be something that's going to be fun to work on. And maybe we get some patients involved and get all the societies and all the specialties involved.
And I think that shared decision-making that you mentioned was another kudos to CMS. They initially, as you know, wanted a validated tool, which there was no such device. And that would kick the can down necessarily. What they asked us to do, and in that spirit collaboration that we talked about, it is the right thing. We've been doing shared decision-making, all of us, for a long time. That's what we do. The encouragement is for everybody to do that. When you see Mrs. Smith in the office, it's our obligation to review the various options in an unbalanced, fair manner, including medical therapy. Balanced manner. Yep, that's right. I'm sitting here in balanced fashion here. But in all seriousness, you give a balanced approach of what we think is best for you. You know, they know that there are options, and then you write that down, not in a smart phrase. It's the same for everyone, but it's individualized to each patient. Why did I choose this particular form of revascularization? Here's what I discussed with who in the room. And if we do that, I think we're going to be in a good spot.
So guys, just on behalf of the team at InspireMD, because we're a big team that depends on you, thank you for your commitment to us. We're invested in this space, but all this investment means nothing without your support. So we appreciate that ongoing. And, together, this makes up a good future for us all. So we'll keep investing, and thanks for the time.
We thank you.
Come back next year. All right. Good, guys.
Thanks all.